So now I would like to introduce Andrew Brose, who's going to share with us how some case studies on how Mass Design Group has used a truly human-centered design approach to its healthcare, education, and housing projects across Africa. Andrew Brose leads Mass Design Group's laboratory in South Africa, established to address regional issues of inequality in housing, environment, and health. He originally joined Mass Design Group in 2010 as a design fellow in Rwanda, where he worked on the design and construction of projects across the region, including Umubano Primary School, Mubuga Primary School, Butaru Doctors Housing, and Ringwavu Village Housing. Please forgive me, the pronunciation may not be 100% right. In 2014, Andrew moved to the DRC to serve as the project manager for the Elima Conservation School, where he supervised the construction management and documentation of the unique engagement process. He received a Master's of Science in Architecture and Building Technology from MIT, where he was the recipient of a Tata Center Fellowship and the 2018 Takafos Award for Building Technology. Andrew completed his Bachelor of Architecture at the University of Oregon and is a SACAP professional architect. Andrew, we're really looking forward to your presentation. Over to you.
Thanks, Kate. Let me pull up my screen. Well, I think this conversation this morning has been perfectly oriented. I want to get into some built applications, but also thinking about scalability of these projects and how we carry this great work that we've seen presented from everyone this morning, and thinking about how we start to develop a series of tools or replication in the different projects and with the different partners we're working with. As an organization, we really do truly believe that building design, when done correctly, can provide healing, it can provide dignity. Our first built project, the Butaro District Hospital, really spurred this on, and it taught us a great deal about how to think about environmental control, patient flow, and how not only in health institutions, but also in the housing and access transportation networks, that the built environment does play a truly critical role in the health and well-being of individuals. We've also learned that we need to define healing in the broadest sense of the word. And the National Memorial to Peace and Justice in Alabama in the USA has seen hundreds of thousands of visitors since its opening, and has mobilized a national conversation on racial injustice and historic trauma. And it's really begun to change national policy in the US and spur conversations globally. So for us, healing is really broader than our bodies. Justice and equity are necessary for true public health. And this again is why we are a mission-forward, mission-driven organization, believing that design is never neutral, that I can either hurt or I can heal. And we continue to advocate for a mission to research, build, and advocate for architecture that promotes justice and human dignity. In healthcare spaces, human-centered and contextually aligned design can not only direct health outcomes, but support care experiences that are respectful and dignified. And this morning, I actually want to speak directly to spaces which provide health, bodily health, specific for mothers and children and providers. And we know from our experience, and I think we've had a good introduction to this morning, that through all the work, we continue to find the way that buildings are designed, when focused on the end user, can provide healing and can provide dignity. But we have to come back to this critical question, which is, who is the end user? And how should we be engaging and learning from these users for our next project, for the projects in which we work with? If we're not having conversations with the participants, to truly be human-centered means that we need to be engaging at every step of the design process. Our first experience with the built environment is really when we are born, whether you're born in a hospital, in a birth care facility, or you're born at home. Maternal and newborn care is really a critical space which our design profession has oftentimes institutionalized this practice. We've made mothers and children patients of a healthcare system, and it's failed to recognize a lot of the challenges and the opportunities to create more of a comfort and dignified experience, especially for mothers in rural settings or mothers who don't access the health infrastructure often. So I'd like to speak to 3 projects at various scales, which focus on the child, the mother, and the provider, who are all users of health facilities throughout the pregnancy, labor and delivery, and postnatal care process. As an overview of the pregnancy journey, we know that a typical pregnancy usually lasts 40 weeks. But there's a delivery process, which is different from others. Can be very quick. It can also be a very long laboring process. Moving into an active labor and then a delivery in a facility or at home. And then postnatal care, which is actually a really critical period for health intervention and also protection and care of a mother and a child. That first day right after a child's birth is when 70% of postnatal deaths occur. And it's really critical that there's oversight and there's monitoring of the health of the mother and child in that time period. Postnatal care is equally important. Follow-up with mother and child at a health facility with a provider is critical. What we found oftentimes is that mothers don't have access to health facilities, either because they're too far, they're costly or expensive, that providers are overworked, and they are not able to see mothers, they're not able to take care of children. And so the built environment can play a large role in both being welcoming, can reduce provider stress or provider workload. It can provide a space which encourages a mother to stay for those critical hours after a birth process. And it can also encourage for an engagement with companions and attendees. For the maternity waiting villages in Malawi, we worked with the University of North Carolina and the Clinton Health Access Initiative to test the impact of new prototypes, pushing against the traditional Ministry of Health model. The typical Ministry of Health model or government model for a maternity waiting home looks like this block of hostel rooms. And the intention behind this is very good. It's to bring mothers to a healthcare facility early in the pregnancy and delivery process, labor process, so that mothers who oftentimes don't know their delivery or due date can come and wait for that labor to begin. And they're directly connected to a health facility for their antenatal care and antenatal checkups to monitor and make sure that there's no complications or challenges with the pregnancy. And so mothers may be traveling from nearby and staying in this facility for a few days, or they may be traveling from a couple 100 kilometers away and staying for a week or sometimes up to a month. So these facilities, maternity waiting facilities, are really critical in their ability to reduce the chance for any complication or challenges during that labor and delivery process, thus reducing the possibility of sickness or death of both the child and the mother. What we really propose on this project is a prototype design for families and patients, patient attendants, giving space to those who come to support pregnant mothers. So not only is the facility designed for the mothers who are waiting to go into labor, but also for the attendants who are critical to that process. Oftentimes these facilities are overworked. These providers are overworked, the facilities are overburdened, and the attendants or the companions, oftentimes family mother, mother-in-law, sister, will be coming along with that mother to support them throughout the entire process, whether it's cooking food, looking for lab results, maybe notifying the provider of when a mother is in labor or in distress. And so we used more of a village model, taking cues from a collective way people are already living in Malawi, to design a facility which is a series of blocks built from soil on the site using compressed stabilized earth block and truss, wood trusses, again, locally found and crafted and installed. And this model not only becomes one which is scalable and repeatable, but also becomes one which is more familiar and more private. And it begins to provide a level of dignity and access, which wasn't previously found at a lot of maternity waiting facilities in Malawi. really, it's a good example of one facility, but we have to begin scaling beyond the single mother, their sole companion, and the lone midwife. When we're looking at the hundreds of thousands of births that occur weekly in these regions, we need to be thinking about how to scale this. And we as professionals don't have the ability to be designing every single facility. So we need to start to work with our partners and our clients and others within the Ministry of Health, government providers, as well as the foundations and NGOs who are supporting this kind of research, to think about how to begin to provide prototypical models and prototypical spaces. We had an opportunity actually just this last year to work with UNOPS in their response to a recent Cyclone Idai and the attention it brought to the ongoing climate crisis in Zimbabwe and Mozambique. The crisis, which has been exacerbated by increasingly prevalent natural disasters, where over 250,000 people in Zimbabwe alone were affected by the 2019 cyclone, which caused massive flooding and landslides, and then more than $600 million in damages. And our challenge on this project, working with UNOPS and local partners, was how can we design a prototypical primary maternity clinic that can be replicable for the reconstruction of damaged facilities and adapted to diverse contexts. So looking at myriad of health facilities which were damaged by the cyclone, and looking at how they can not only be climate resilient and safe, but also continue to provide better access and better care for mothers who, again, might be traveling from long distances across the border from Mozambique or other areas in rural Zimbabwe. This is a project we did in partnership with Kunle Adeyemi out of Nigeria, and a good friend of ours. And together we began to put together a series of questions and tools. And we had a week together traveling through Zimbabwe and asking questions directly of mothers, of providers, of companions, asking questions about space. And we put together some pretty quick tools and showed some examples from other projects we worked on and projects that we know have been successful in the past. Asking questions about comfort, about care, privacy, about that labor and delivery process. What does it look like? Do you stand? Are you walking, moving? What does it mean for it to have mobility? And from those answers, we put together a series of model or kit of parts, modules that could be moved around to fit different site contexts, different access needs, provider requirements. These were looking at facilities which have had different level of care and were in different states of repair. And so looking at how to plug these into a myriad of facilities across Zimbabwe and allowing them to be scalable and allowing them to sequence in a way that meets and responds to topography, adjusts to site and climate and solar orientation. And so using this kit of parts, which is really focused on an outpatient department, a labor and delivery ward, a new maternity waiting facility, as well as an antenatal and postnatal ward, we began to look at how these 5 different legs of a star configuration could orient and could shape itself to meet those different contexts and those different needs. So we're actually beginning the construction of the first of 3 facilities now with UNOPS in Zimbabwe, and looking at how to apply this and adapt this to a myriad of contexts moving forward. Again, designating the end user, scaling for multiple users across contexts is important. But the stage we're at now, and I'm really excited about the project that we're currently working on, which takes us all one step further in developing a set of shareable tools, which we can disseminate further, looking at opportunities to push us beyond the space in which we're working now, thinking about how a set of global tools, which not only provides a set of questions and surveys and activities, workshops, simulations, which we do with the myriad of stakeholders, but also does an assessment of existing facilities so that these tools can then be used to inform the design process. If we don't have the information set up beforehand, we're going to continue to rely on a set of prototypes or a set of standards which continue to ignore existing contexts or needs of the various stakeholders. So this is a project we're doing with a series of great partners. It's being led by the Institute for Healthcare Improvement. It's being funded by the Bill and Melinda Gates Foundation, the Elsa Peter Soderbergh Charitable Foundation, and then it's mass along with two local partner architecture and consulting partners, Faisal Gorgas Consult in Ethiopia and ICDDRB in Dhaka, Bangladesh. And this really stemmed from IHI's work in the two countries of Ethiopia and Bangladesh, and the feedback which they overwhelmingly are receiving at the thousands of health facilities in which they provide programmatic support, in that the infrastructure continuously fails to meet the needs of its users. And we keep hearing about some of the challenges around cultural hesitancy, language barriers, insufficient spaces for families and companions, lack of privacy during labor, and the ignorance or the lack of attention for religious and cultural practices, which are really pivotal and instrumental for any home birth, which have been completely pushed out of the health institutions. Again, as we've continued to push mothers and children into more of a patient-focused trend of health delivery rather than a care-based model of delivery and care. And we're looking at a number of different metrics in order to show success for these projects. And we're at the very early stages of this work, but we actually just came back from Ethiopia 2 weeks ago from our first immersion. And the team is actually going on their second immersion today. Bangladesh team will be going their first immersion next week and then conducting another immersion very soon. And what we've done for this project is selected 2 health centers. So your first level of primary care, and then 2 general hospitals. So looking at ranges and scales of care facilities, both in Ethiopia and in Bangladesh, in different districts and different contexts with different topographies and cultural contexts. And we're employing this tool to test it and to think about what are the questions that need to be asked and how can they be asked appropriately. And the way that we've developed this together between IHI, MASS, and our local partner between Ethiopia and Bangladesh is the creation of immersion tools, the translation of those tools either into Bangla or Amharic for Ethiopia, and oftentimes even translations to local dialects like Afar, as we were working in the Afar region in eastern Ethiopia. Engagement on the site, both with community and the facility, and then the collected outcomes using film, data input from digital tools, and then capturing audio from those engagements as well. And all that data comes back to us and serves as a repository for information, which gets used to inform the design that we work on collectively for a series of model facilities. These immersion tools, which we've developed together, are really grouped into 2 areas: engagement guides and assessment guides. Really, one to collect information from people as part of a human-centered design process. And then the second is to collect information from the buildings. What's working, what's not, how is the structure designed, what are the opportunities we have to modify or manage or improve, what are new opportunities for design or construction on an existing site, and how can it be implemented further or improved beyond what's in existence now. And these series of documents are put together in a set of binders and worksheets and sent out with teams of architects, engineers, social workers, Ministry of Health representatives to go to the field to engage with mothers, providers, companions, local leaders and officials. And what we've done is we've actually looked at a series of different events and activities, from semi-structured interviews, quantitative surveys, a facility walkthrough with a mother, observation and shadowing activities, experience simulations, journey mapping, co-design workshops. So a myriad of different activities and events which are critical to this purpose-built engagement process. And we've submitted these in the respective countries for IRB approval, so they are approved for engagement and for publication in the future. And then we can look at review boards to ensure that what we're doing is locally and culturally relevant and contextual. The assessment guide is really, I think, the technical aspect of this, which is, again, looking at what is in existence and how can be modified for future use. How does it work given current waste systems, water provisions, electric and power demands, and needs. And the entire process is really focused on how we can have specific interventions for maternal and newborn health facilities, but looking at the entire hospital or health center as a way to inform the entire process and to look for future engagement with the Ministry of Health and local leadership to make improvements to those health facilities in general. So as I mentioned, we've just started this process, implementing these and testing these tools. We'll be moving into a concept and schematic design process next. We're using the outcome of these tools to inform both the design intervention, which will inform a series of built outcomes, a set of documents which inform new models of construction, and then a set of global goods, which will be publicly disseminated in the next year and will be shared with other partners to increase in scale across multiple sites and multiple activities. So as I've mentioned, we've just come back from our first immersion. I wanted to just show a short video. I think this is an opportunity just to show some of what we've been doing. And again, I think what this does and what I appreciate about this little video is it gives an idea of how this engagement in human-centered design approach needs to be done on a day-to-day and related to the care of mothers, providers, and children. So I'll end there. I think that this is something we hope to carry through on a number of other projects moving forward, and we're very excited about the opportunity to begin sharing this tool in the next year and how we can continue speaking with other partners to improve it, but also to use it to inform future design processes moving forward. Again, it is critical to any human-centered design process to be having conversations with the end user. In this case, specifically speaking to the mothers who are part of this birth journey, so that they are not only feeling a level of dignity which wouldn't necessarily be provided for in these health facilities typically, but also that they continue to find a level of safety and comfort which they would assume for any healthcare or any delivery at home, and that it feels like one which they are continuously welcome to and can come back to in the future. So I'll leave it there, and thanks again for everyone for attending. I'm open for any questions, and I'm looking forward to the conversation moving forward.